My first impression was that this was really important results, a landmark study, because alivocumab both reduced cardiovascular morbidity and also all-cause mortality. The reduction in all-cause mortality, I think, is a very important additional finding in the ODYSSEY OUTCOMES trial. Although this was not originally powered to study that, it's a very nice signal to find a reduced all-cause mortality. But of course, the most important finding is that it's reduction in cardiovascular morbidity, the main endpoint of MACE. The finding of the ODYSSEY OUTCOMES that the results were most pronounced in those with LDL above 100 milligram per deciliter at baseline makes perfect biological sense. This is what we would have expected. So I think it is very important to take that finding seriously. And in any case, certainly this is what will happen anyway in many countries in the world, because as long as the drug is relatively expensive, most authorities, it be health authorities from the public or insurance companies, will only ask what patients can we give the drug to that have the very highest benefits. And it so happened in this trial to be the ones with LDL above 100 milligram per deciliter. This is what we expected, and this is also what the payers will ask for. So you could say that this is a very important finding. The ODYSSEY OUTCOMES certainly will be important for revision of guidelines all over the world. I think not only the ODYSSEY OUTCOMES, but together with the other PCSK9 inhibitor trials, because we now have 3 trials that show when you give PCSK9 inhibitors on top of maximum statin tolerated dose, then you have reduced cardiovascular morbidity, which is very important. And then, of course, the ODYSSEY OUTCOMES also reduced all-cause mortality. So the 3 studies together will change guidelines, I'm sure. I think if it was in the ideal world where drugs did not cost anything, then you would use max tolerated statins or maximal statins, because this is really evidence-based. And then you would probably use PCSK9 inhibitors on top of that. However, because there's a cost issue, we would still for years have first maximal tolerated statins, then ezetimibe, and then PCSK9 inhibitors on top of it.